صباح الخير. السلام عليكم ورحمة الله وبركاته. إن شاء الله تكونوا جميعا بألف خير وصحة وسلامة، وأهاليكم إن شاء الله بألف خير وصحة وسلامة، وربنا يحفظكم جميعا ويحفظ جميع البشر يا رب. اليوم موضوع محاضرتنا عن الأورال ميكوزا 2 the second part of oral mucosa. طبعا المحاضرة تشمل المواضيع التالية: Gingiva, Alveolar Mucosa, Hard Palate, Soft Palate, Tongue, Floor of the Mouth, and some clinical considerations. By definition, the gingiva is the portion of the oral mucosa that surrounds and is attached to the teeth. It has two main regions: the attached gingiva, which is directly bound to the underlying bone and tooth, and the free gingiva, which is narrow and not bound to any bone or tooth. The free gingival groove demarcates the free from the attached gingiva in 40% of cases. This figure shows the two parts of the gingiva, which is the free gingiva and the attached gingiva. Here, this part is the free gingiva. The remainder of the gingiva is called the attached gingiva. And the attached gingiva has three parts. The first part of the attached gingiva is bound to enamel. Second part of attached gingiva is bound to cementum. The third part of the attached gingiva is bound to alveolar bone. Here in this figure we see that starting from the cemento-enamel junction, which is here, there is junctional epithelium, which is smooth and doesn't have raised ridges. This binds the first part of the attached gingiva to the enamel. The top part of the gingiva is the free gingiva, and it's lined by sulcular epithelium, and the sulcular epithelium is thicker and has raised ridges. The gingival margin is the coronal limit of the free gingiva, which is here. The gingival sulcus is the unattached region between the free gingiva and the tooth. So it's a space. Gingival sulcus is space that is between the free gingiva and the tooth. Junctional epithelium is the area where the gingiva is bound to the tooth. So here you see this epithelium. It's smooth. It's up till here. When we start to see raised ridges, then we are in the region of sulcular epithelium, which lines the free gingiva. Free gingival groove follows the contour of the cemento-enamel junction, and as we know, the cemento-enamel junction or the cervical line of teeth is not a straight line, so the free gingival groove is not a straight line. There are principal fibers, which are collagen fibers, that run from the cementum to the lamina propria of the gingiva. We have heavy epithelial ridges for the gingival epithelium, which is the external side of the gingiva, whether it's the attached part or the free part. Healthy gingiva shows stippling corresponding to deep epithelial ridges. So these stipplings appear externally, and they correspond to the site of deep rater ridges in the gingiva. Interdental papilla, it's part of the gingiva that fills the space between teeth. The external surface of the attached gingiva is masticatory mucosa. You see here, this is the epithelium. It has deep ratty ridges, finger-like projections. This is characteristic for the gingiva, the external side of the gingiva. The epithelium is classified as masticatory mucosa because it is keratinized, as you see here. It has a layer of keratin, and this keratin can be orthokeratinized or parakeratinized. In 75% of cases, it's parakeratinized. The remainder is orthokeratinized. The rater ridges show variations, but they are in general finger-like pointed projections. The gingiva, particularly the attached part, the part of the gingiva that's attached to the alveolar bone, fits the term mucoperiosteum, which means that the mucosa, which includes epithelium plus lamina propria, is directly attached to the periosteum, which covers the alveolar bone, and there is no submucosa separating them. Here we see part of the attached gingiva that is attached to the enamel. So here we start from cemento-enamel junction. You see here this epithelium is called junctional epithelium. We see it's thin, smooth, and it doesn't have rater ridges. If we go up, we will find the sulcular epithelium, which has rater ridges and not bound to the enamel. And this is the external side of the gingiva, which is keratinized epithelium, and this is the lamina propria of the gingiva. Again, here we see the same thing. We see junctional epithelium starts from cemento-enamel junctions and reach up here where the sulcular epithelium starts, and you can find rater ridges in the area of the sulcular epithelium. The free gingival mucosa is identical to the attached gingiva, which means externally they are both have keratinized epithelium. The gingival sulcus, which is the space between the free gingiva and the enamel of the tooth, is 0.5 to 2 millimeter deep in healthy gingiva. Sulci deeper than 3 millimeter are considered periodontal pocket. When the sulcus is deeper than 3 millimeter, it means there is a chronic inflammation in the periodontium, which includes gingiva, periodontal ligament, alveolar bone, and the cementum. When these parts of the periodontium are inflamed for a long time, this will lead to destruction of the junctional epithelium and deepening of the sulcus, and now it's called periodontal pocket. Here we see the same thing. We see here junctional epithelium, then we see where we start to find rater ridges, the area of sulcular epithelium. Here we see the external gingival epithelium, gingival sulcus is here, which is the space between the free gingiva and the enamel of the tooth. Sulcular and junctional epithelia form the gingival cuff. Sulcular epithelium has more folded interface with the lamina propria, means it has raised ridges, tags of enamel cuticle between the two epithelia. Different cytokeratin profiles between the sulcular and junctional epithelium. Sulcular epithelium is thin and non-keratinized, but it's thicker than the junctional epithelium. Junctional epithelium is also non-keratinized. The base of the sulcus is at the same level as the free gingival groove. The free gingival groove is external, and the base of the sulcus is internal. Internal means toward the tooth, external means away from the tooth. The junctional epithelium extends from the cemento-enamel junction to the sulcus base. So extends from here up where we start to see sulcular epithelium. It's about 2 millimeters. It's thinner apically, means it's the thinnest near the cemento-enamel junction. It has 2 layers under the microscope. Of course, you can, at higher magnification, you can find 2 layers of epithelia. The first layer is called the stratum basale, which is the basal cell layer, and the second layer is the stratum spinosum, which is the brachial cell layer. The basal layer is toward the lamina propria of the gingiva. It will be toward the lamina propria, and the stratum spinosum will be toward the enamel of the tooth. It has 5 to 6 days turnover rate. Junctional epithelium is originally derived from the reduced enamel epithelium. That's why they have the same cytokeratin profile. We'll talk more about the reduced enamel epithelium when we talk about tooth development. But for the time being, what you have to know about the reduced enamel epithelium is that the epithelium that protects the tooth before eruption. It covers the crown of the tooth before the tooth erupts. It has the junctional epithelium has a smooth connective tissue interface, means doesn't have raised ridges. It has 2 basal lamina. One is called internal and the other external. The internal is toward the enamel, and the external is toward the lamina propria of the gingiva. Lamina densa in the internal lamina is not clearly delineated. It lacks collagen type 4 and laminin. So the internal basal lamina of the junctional epithelium is a modified basal lamina because it lacks collagen type 4 and lacks laminin. But the external basal lamina, which is toward the lamina propria of the gingiva, is like any basal lamina. It has all the components of the basal lamina in any other part of the body. Smaller number of desmosomes result in spaces making up to 5% of the tissue volume. Also, another difference between the other epithelia and the junctional epithelium, that it has a smaller number of desmosomes. This will lead to more spaces within the tissue, and this space is important so that the sulcular or crevicular fluid and immune cells pass through these spaces to fight against germs that may gain access to the gingival sulcus. Here, this represents the junctional epithelium, and it shows that it has two basal laminae. This is the internal basal lamina toward the enamel. This is external basal lamina toward the lamina propria of the gingiva. This layer here is the basal layer of the junctional epithelium, and these two rows are part of the stratum spinosum, and these are the spaces between the cells to allow the movement of the curvicular fluid or sulcular fluid. The length of junctional epithelium varies with the stage of eruption. When the tooth first erupts, most of the enamel is covered with junctional epithelium. 1/4 of the enamel is covered by the time the tooth reaches occlusion. Later on, junctional epithelium will lie close to the cemento-enamel junction. In cases of gum recession, we find that normally when we have chronic periodontitis or when we have using excessive force while tooth brushing. These normally leads to gum recession, and when there is gum recession, the junctional epithelium makes attachment apically, meaning it makes attachment toward the cementum. The curvicular fluid. The intergingival junction seals the lamina propria from the oral environment. Gingival curvicular fluid or sulcular fluid is the fluid within the sulcus. It results from the permeability of the junctional epithelium. Material passes from the lamina propria into the sulcus. The curvicular fluid contains polymorphonucleosides, which are important in the defense mechanism against germs. Interdental papilla. Interdental papilla is the part of the gingiva between teeth. So it occupies the area between adjacent teeth. Its shape and size depend on the shape and contact between teeth. Wedge-shaped appearance on the buccal and the lingual sides. So it's basically triangular in shape, buccally and lingually. It's pointed between anterior teeth because the buccolingual dimension is smaller in anterior teeth as compared to posterior teeth. The interdental cull is a curved depression across the buccolingual plane. We find that in posterior teeth. In the interdental papilla between posterior teeth, because they have larger buccolingual dimension, so there is a depression area underneath the broad contact points between the posterior teeth. It fills the contour around the contact point. Here we see interdental papilla between two teeth. This interdental papilla, it has free part, it has attached part. So it's like gingiva. We have free gingiva, attached gingiva, interdental papilla. It's gingiva, it has free part, not attached to the tooth, and a part that is attached to the tooth by junctional epithelium. The free part is lined with sulcular epithelium that is not bound to the tooth. The cull region, which is here, and here it's depression area. The epithelium of the kull is continuous with the junctional epithelium. It's non-keratinized and initially derived from the reduced enamel epithelium. So here the junctional epithelium, the epithelium in the interdental kull region is very similar to the junctional epithelium. It's smooth, thin, and doesn't have rated ridges. And also it's derived from reduced enamel epithelium, and it has the same cytokeratin profile to the junctional epithelium. Spaced teeth have no kull. They have thin keratinized gingiva instead. The gingival lamina propria. It has dense collagen bundles which support the free gingiva, bind the attached gingiva to the alveolar bone and the tooth, and play a role in linking teeth to each other. The principal fibers in the lamina propria of the gingiva are divided into groups according to their location. There are many types of the principal fibers in the gingiva. These include dentogingival fibers, longitudinal fibers, circular fibers, alveolo-gingival fibers, dentoperiosteal fibers, transseptal fibers, semicircular fibers, transgingival fibers, interdental fibers, and vertical fibers. This figure here shows some of them. Dentogingival group, you see in the figure, it starts from cementum, inserted in the cementum, and go in the direction of the lamina propria of the gingiva. There's another group inserted in the crest of the alveolar bone and run toward the lamina propria of the gingiva. These are called alveolo-gingival group. There is also a group inserted in the cementum and go toward to be inserted at the external side of the alveolar bone. These are called dentoperiosteal group. There is also a group that appear in cross section here. Appears like dots. They are cut in cross section. The section here is longitudinal, but these fibers are the direction of the section is at right angle to them. So that's why they appear circles. These are called the circular group. This figure shows also some of the gingival fibers. This here we have alveolo-gingival group, and here the fibers running in this direction are the circular group. This section is longitudinal section at the area between in the interdental papilla between posterior teeth, where we see the depression kull region. We see two types of fibers that are cut in cross and appear circles, and they have two levels. The level above is the dentogingival group, and the level below is the dentoperiosteal group. Here in this figure we see different types of gingival fibers. Here A refers to dentogingival fibers from cementum to the lamina propria of the gingiva. B refers to this group, which is the longitudinal fibers. C, this group, these dots, they are circular fibers. D, alveolo-gingival fibers. E, dentoperosteal fibers. F, transseptal fibers from cementum to cementum above the crest of alveolar bone between neighboring teeth. G is called semicircular fibers. H are called transgingival fibers because they originate from cementum and insert in cementum, but not for neighboring teeth. From one tooth, from the root of one tooth to the root of the next neighbor, not the first neighbor. First neighbor would be like transseptal fibers, but these, they go to the second neighbor root, so they are called transgingival fibers. I, they are called interdental. They run, some of them run in this direction, some in this direction. And J, vertical fibers. Here we are talking about the characteristics of the lamina propria of the gingiva as compared to the periodontal ligament. The fibroblasts lack alkaline phosphatase. They have less contractile protein. They can release more prostaglandin in response to histamine. They have less ground substance, less collagen type 3, lower turnover rate, and it has rich vasculature because it has two plexi, one beneath the oral sulcular epithelium and one beneath the oral gingival epithelium. The attached gingiva is demarcated from the alveolar mucosa by mucogingival junction. So the mucogingival junction is the junction between the attached gingiva and the alveolar mucosa. You see here in this figure, there is a line demarcating the area of the gingiva, which is pale pink in color, and the alveolar mucosa, which is more reddish in color. The line between them is called mucogingival junction. It's about 3 to 5 millimeter below the crest of the alveolar bone. Alveolar mucosa, it lines the lower part of the alveolus. The upper part of the alveolus is lined with with part of the attached gingiva. It's absent in the palatal side. It has loose submucosa that's rich in elastin. So the alveolar mucosa is more elastic and more mobile than the gingiva. The submucosa is attached to the periosteum because underneath the alveolar mucosa we have the alveolar bone, part of the alveolar bone. The epithelium of the alveolar mucosa is thin and translucent, and it's non-keratinized. In the gingiva, the epithelium is keratinized. In alveolar mucosa, the epithelium non-keratinized. Blood vessels in the alveolar mucosa, they are located near the surface, which contributes to the reddish appearance of the alveolar mucosa as compared to the pale pink appearance of the gingiva. It contains the region of the alveolar mucosa, has minor salivary glands in the submucosa. Here we see the mucogingival junction, which is the junction between the gingiva, which is keratinized, and the alveolar mucosa, which is non-keratinized. The palate, which is the roof of the oral cavity, is divided into two main areas, hard palate and soft palate. The hard palate is the area of the roof of the mouth that is supported by bone. Soft palate is located more posteriorly, and it is not supported by bone. It's supported by muscle. The mucosa covering the oral side of the hard palate is classified as masticatory mucosa. It's keratinized epithelium. All masticatory mucosae has keratinized epithelium, whether ortho or parakeratinized. In the hard palate, in the central region of the hard palate, which is called midline palatine raphe, we do not have submucosa. As you see in this figure, here we have epithelium of the hard palate, which is keratinized epithelium, lamina propria, about same thickness of the epithelium, and then we have the supporting bone. This is the supporting bone, and it's covered by periosteum. We do not have submucosa in this region. There is no submucosa between the lamina propria and the periosteum. So this section is taken from the midline of the hard palate. In the other regions of the hard palate, we have submucosa, and we will talk about in the coming slides. Here, in this section, you see we have epithelium, lamina propria, and then we have submucosa. The submucosa is fatty in nature. You see fat cells, adipocytes, which here is the main characteristics of the submucosa. This is known to be in the anterolateral region of the hard palate. I mean the oral side of the hard palate. Submucosa exists where the palate meets the alveolus. It contains the main neurovascular bundle, minor salivary glands posteriorly, adipose tissue anteriorly. So this section is from the anterolateral region of the hard palate. If it's from the posterolateral region of the hard palate, you will find, instead of fat tissue, you find minor salivary glands, which are mucus type, completely mucus. Here we are looking at the nasal side of the hard palate. This is the bone of the hard palate. This epithelium, as you see here, is respiratory epithelium. It's pseudostratified columnar ciliated epithelium with goblet cells. You can see the goblet cells, white circles within the epithelial layer. We have here lamina propria. Lamina propria has mucosal glands. They are not salivary glands. They produce mucus. They are called mucosal glands. And then we have submucosa, and this submucosa is rich in large blood vessels. Large blood vessels, which are important for keeping the inhaled air warm before for making the inhaled air warmer, so that when it goes to the lungs it will be warm instead of being cold. Nasal surface of the palate is lined with respiratory epithelium. It's ciliated columnar epithelium with goblet cells. We have vascular submucosa with minor glands. The minor glands are mainly located in the lamina propria, and the blood vessels, large blood vessels, are mainly located in the submucosa. Here we see the junction of the hard palate with the soft palate. We see the epithelium of the soft palate is thick and non-keratinized, and the epithelium of the hard palate is thinner and keratinized. Here we see taste bud. The soft palate has is a non-keratinized lining mucosa. It has short, broad connective tissue papillae, and it has submucosa with many salivary glands. And these salivary glands are completely mucus salivary glands. Floor of the mouth. Both floor of the mouth and the ventral surface of the tongue have a typical lining mucosa, meaning that they are both non-keratinized. There is a need of mobility here for the ventral surface of the tongue against the floor of the mouth, so mobility would be easier between two smooth surfaces, which means two non-keratinized epithelia against each other. The mobility would be easier. The floor of the mouth has thin non-keratinized epithelium with short papillae. The submucosa of the floor of the mouth is considerable, but almost absent for the ventral surface of the tongue. We don't have submucosa in the region of the ventral surface of the tongue, but we have considerable submucosa in the floor of the mouth region. The submucosa of the floor of the mouth has the sublingual gland, which is a major salivary gland that is mixed but mainly mucus, and we have other minor salivary glands in association with the sublingual gland. They are also mixed but mainly mucus. The lamina propria of the floor of the mouth is highly vascular. That's why the floor of the mouth is considered as one of the drug routes for some drugs like nitroglycerides, which are taken in cases where the person feels signs of angina to save himself from developing myocardial infarction. Here we have a sagittal section of the anterior region of the tongue. This is the dorsal surface of the tongue. This is the ventral surface of the tongue. In both cases, we see that we have lamina propria, but we do not have submucosa. So the lamina propria is directly bound to the supporting muscle. The epithelium of the ventral surface is thin, non-keratinized. The epithelium of the dorsal surface of the anterior two-thirds of the tongue is thicker, keratinized, and it has filiform papillae. Anterior two-thirds of the tongue are divided from the posterior one-third by sulcus terminalis. It's V-shaped sulcus that separate the anterior two-thirds of the tongue from the posterior one-third of the tongue. Anterior two-thirds of the tongue are covered with papillae. There are different types of papillae. We will talk about them shortly. The posterior one-third has lots of lymphatic nodules. In the posterior one-third, you see lots of lymphatic nodules. These are called lingual tonsils. The lingual tonsil area is considered as specialized mucosa. Anterior two-thirds of the tongue is also considered specialized mucosa as well. There are four main types of papillae covering the surface of the tongue, meaning the anterior two-thirds of the tongue. The anterior two-thirds of tongue dorsum. These papillae include filiform papillae, fungiform papillae, foliate papillae, and circumvallate papillae. Filiform papillae largely covers the anterior two-thirds of the dorsum of the tongue. They are heavily keratinized. It could be orthokeratinized or parakeratinized. They have central core of lamina propria with secondary papillae branching from it. They have mechanical function as they are highly abrasive, so they assist in mastication. You see here the filiform papillae are conical in shape. Here we see lamina propria, here we see the muscle. Second type of papillae on the anterior two-thirds of the tongue dorsum are the fungiform papillae. Are found as isolated, elevated, mushroom-shaped papillae scattered between filiform papillae. So this here is a fungiform papilla. It's they are circular in shape and they are more reddish. The epithelium covering them is either non-keratinized or slightly keratinized. They have a considerable lamina propria core that's rich in vasculature. They have taste buds on the top surface, about 150 to 400 micron in diameter, the fungiform papillae. The epithelium covering them is thin and it can be keratinized or non-keratinized. They have vascular lamina propria core. Taste buds could be found on the top surface of these papillae. Foliate papillae, they are located here and here. They are located at the most posterior lateral region of the anterior 2/3 of the dorsum of the tongue, and they are a group of alternating ridges and grooves running in vertical direction. Foliate papillae may be found as 1 to 2 longitudinal clefts at the side of the posterior part of the tongue, posterior part of the anterior 2/3 of tongue dorsum. They are covered with non-keratinized epithelium. Taste buds may be found within their epithelium. The taste buds normally found in the foliate papillae on the sides of the grooves between the ridges. Circumvallate papillae are large and rounded. They are surrounded by a trench-like structure. They are not projected beyond the surface of the tongue. They are covered with non-keratinized epithelium, and taste buds are on the internal walls of the trenches. Here we see a circumvallate papilla. It's large. You see groove on either side. It's called trench or groove. The taste buds are on the lateral sides of the papilla, near the groove. Here they are associated with a special type of salivary gland. It's called von Ebner's gland, which is the only completely serous minor salivary gland. They make watery secretions. It's serous, completely serous, so its secretions are watery. The gland empties its secretions at the bottom of the groove or trench, and this is important for continuously flushing the trench so that food debris and bacteria and germs do not accumulate in the trench area. Also, these serous secretions are important in dissolving the food chemicals, so that can be sensed by the taste buds, which are located on the sides of the papilla. Von glands are serous glands empty into the base of the trench. The mucous glands could be seen within muscles and in the posterior region to the circumvallate papillae. Circumvallate papillae are located just anterior to sulcus terminalis. And posterior to sulcus terminalis, we have the posterior 1/3 of the tongue dorsum. Here we see the taste buds on the sides of the papilla. Here we see the trench, the space, and here we see von Ebner gland. Von Ebner gland, as we said, empties in the bottom of the trench. Here also we see the bottom of the trench where the von Ebner gland empties its secretions. Taste buds are chemoreceptive organs of taste. They are found in circumvallate papillae, fungiform, and foliate papillae, in addition to the palate and the epiglottis. Palate includes hard palate and soft palate. The epiglottis is located posterior to the most posterior region of the posterior 1/3 of tongue dorsum. The taste buds have a small pore opens from the surface into the bud, which is A here. It's called taste pore. It's a little hole, and it's B here. It's a little hole where dissolved food chemicals can enter, so that the receptors of the sensory cells of the taste buds can interact with them. So here A, in this figure, A is a taste bud, B taste pore, C basal cells, stem cells for the taste cells and the supporting cells. D here we have taste cells, receptor taste cells, and other supporting cells. The main types of cells in the taste bud, we have taste cells and supporting cells. The basal cells are also considered taste cells. They are called type 4 taste cells. We have 3 types of taste cells in this region: type 1, type 2, type 3, and type 4 is the basal cells. 4 sensory cell types. Type 1 cells appear dark in electron microscopy images. Type 2 and type 3 taste cells appear light. Type 4 are the undifferentiated progenitor cells, and they are progenitors for the other 3 types of cells. So here we have the basal cells, type 4 taste cells. Here we have type 1, type 2, and type 3. Because this is an electron microscopy image, the dark cells, like this one, are type 1, and the light ones, like this, they are either type 2 or type 3 taste cells. Lingual tonsils are masses of lymphoid tissue on the lateral border of the posterior 1/3 of the dorsum of the tongue. They are part of the what is called the Valdez ring of tonsils. This ring includes the lingual tonsils, palatine tonsils, and the pharyngeal tonsils. The lingual tonsils have deep crypts lined with epithelium containing masses of lymphoid tissue. Mucous glands could be present in the region of the lingual tonsils. Here we see a figure for the lingual tonsils. You see the epithelium covering the lingual tonsils is non-keratinized epithelium. We see crypts. We see the lamina propria is populated with lymphatic tissue. So here the lamina propria and part of the submucosa, the superficial part of the submucosa, contain lymphatic tissue. The remainder of the submucosa has mucus type minor salivary glands, completely mucus minor salivary glands. So you see minor salivary glands in the posterior region of the oral cavity, they are completely mucus, like in the posterior lateral region of the hard palate, like in the soft palate, like in the posterior 1/3 of tongue dorsum. All of these regions, because they are posterior, the salivary glands are mucus. In the anterior region, like the submucosa of the lip, the submucosa of the cheek, the submucosa of the floor of the mouth, the submucosa of the alveolar mucosa. The minor salivary glands are mixed but mainly mucus. Now we'll talk about some clinical considerations. Inflammation may lead to changes in the expression of cytokeratins by the epithelial cells. Also, cytokeratins are important in diagnostic histopathology. For example, when we have a neoplasm, tumor, if the cytokeratin profile is close to the normal cells, then we have good prognosis for the neoplasm. When it is far different from the normal epithelium, then it means that we have the neoplasm is poorly differentiated, and the prognosis will be worse. Dysplastic changes revealed by cytokeratin alterations. So similarly, if the alterations is greater, then means more dysplastic changes in the tumor, and this reflects poor prognosis. Also, cytokeratins are important in determining the origins of cysts. So, cysts are formed by epithelial cells, and the origin of the cyst depends on the cytokeratin profile of the epithelial lining of the cyst. Each type of epithelium has its own cytokeratin profile. So by comparing the cytokeratin profile of the epithelial lining of the cyst with the known cytokeratin profiles of other epithelia, they can determine the origin of the cyst. Gingival wounds do not form scars upon healing, and this resembles fetal mesenchyme. Thank you very much. Thank you for listening, and we will talk to you in the next lecture, which will be about the first part of oral embryology 1, which is about the development of the face. Thank you very much, and see you next time. Bye bye.